Chronic pain is the same type of disease where the disease process has procedures now which can help change the pain, either by doing one of three things: fixing the problem, stopping the pain at the source, or modulating how your brain feels the pain. Today, we're going to learn about chronic pain treatment options. We're going to see what options may work best for your personal chronic pain. We're going to hear from Robin, who is a current pain patient under therapy from the exact company that is offering this to us, and then suggest things for you to discuss at your next appointment when you see your pain physician. Next slide, please. Over the last 2 years, things like this Zoom meeting became popular, and people got much better at these Zoom meetings. There's always something. There's always something. The computer's not charged, your internet's not stable, or you can't find a quiet room to find a meeting like this. But our offices have changed quite a bit. Our office changes in all locations that we're located. We have to have temperature checks before we come in. We have to have questionnaires before we come in every day. And at some of the locations, we get tested for COVID every week, whether we want to or not. And if we test positive, we don't come in the office to try to help people. So COVID has changed quite a way how we go about trying to make other people not get sick. Next slide, please. Let's understand what kinds of pain there are. Most pains are from degeneration. Most pains are from arthritis. Most pains are mechanical in origin. That's called mechanical pain. That's when a normal nervous system goes ahead and picks up a problem. And that's why your brain and your spinal cord and your nerves were made, is to pick up problems, help you walk, help you talk, help you think, but also to pick up problems in your environment so that you can avoid pain. That's about 80% of pains. The other 20% of pains are what's called neuropathic pains. Neuropathic pains is when the nervous system itself is abnormal. Let's say you have something like shingles, and shingles goes on your body and you have this horrible pain, you can't even put a shirt on. And then it goes away, but the pain doesn't go away. That nerve has been damaged, and now that is causing your pain. Let's say that you have a bad back, and all of a sudden you have radiating pain down your leg. And that radiating pain down your leg is there whether you sit, stand, lie down. It's because the nerve has been damaged. Will that nerve heal? It's possible. Nerves heal about 1 centimeter every month. So you have a long nerve like the sciatic nerve. How long is that going to take? It could take years before you know if it's going to heal. Most of the time it won't. Either heals early because it's not much of a damage, or you're stuck with it. After you've had something for more than a year, that's chronic pain. Some people say 6 weeks, some people say 6 months, but the 1 year mark, if you have it at 1 year, you're pretty much stuck with it. Other ways to know if it's nerve pain or mechanical pain is if you have nerve dysfunction, like you have a weak leg. You can't walk without your foot dragging. Your grip in one arm is worse than another. You have difficulties holding on a cup, and that cup drops without you wanting it to drop. When you have nerve compression that bad, a neurosurgeon is often who you have to see. It's pretty rare to have nerve pain that bad from a mechanical problem, which is pinching a nerve that has to be fixed. But that's out there. Most of the time you have the pain without the nerve dysfunction. When it turns chronic, you have to ask yourself, how's that changed my life? Someone came through with a chat I looked at as we were sitting here being introduced. They said, how can you improve sleep? That's a great one. When you have chronic pain, it's very hard to sleep. You can't stay in one position all the time. Some of you out there do that. Some of you have family members out there that do that. They stay in one position all the time because if they roll on their left hip, it hurts so much, it takes a long time for that pain to go away because something's getting pinched or something's arthritic. When you have chronic pain, you're not able to do basic housework. You're not able to do regular work and be productive. having to go ahead and be with other family members can be very difficult because they're variable. Playing with the grandchild, what's the grandchild going to do that I can't do, or I'm going to suddenly have to do, is going to give me bad pain. Things that usually are enjoyable, things that make you release your own endorphins, like exercising, walking outside and hiking, you can't do it. Things like gardening, your crafts, the things that make you you, you can't do it. And then finally, as we mentioned, sleep. Next slide, please. Pain is very big. Pain's the number one reason why anyone goes to the emergency department. Pain is the number one reason why anyone goes into a doctor's office. There are lots of different modalities to treat pain. Modalities that go ahead and help cover up the pain, such as a TENS unit, the third one in, opioids, drug pumps. Those things are used to cover up pain. Things that go ahead and fix the problem, surgical interventions, which often come with their own problems, such as failure, infection, scar tissue, nerve blocks that try to stop the pain at the source, physical therapy that tries to build your muscles around those spots that don't work well so that you can still function. And of course, medications. In the 1980s, ibuprofen, which you know as Motrin, came out. And it came out big time. People use it. It comes in 200 milligram pills. Some people can have it to 800 milligram pills. When you start doing any of the pills daily, it's going to add up. I've known many a patient that's come to me because their kidneys don't work very well any longer, because non-steroidal anti-inflammatory drugs like ibuprofen, Motrin, or naproxen has been taken daily with around-the-clock treatments, and now their kidneys have failed them. Next slide, please. 3 different modalities are presented by Boston Scientific. And those 3 different modalities have other competitors, but they still fall into 3 basic categories. The ablation, radiofrequency ablation, spinal cord stimulation, and decompression. Next slide, please. When you treat pain as a pain management physician, you have to look at the patient and treat the whole patient. If someone's depressed, you have to do things to try to help them from being depressed. If it's the pain, you have to treat the pain as a comorbidity with the depression. By using radiofrequency ablation, you are trying to stop the pain at the source of the problem. In the very middle of the slide, you see a word that says probe and disable the nerve. We are fortunate that much of the arthritis that we have in our neck, thoracic spine, or lumbar spine can be treated with this modality. The idea is you do a nerve block and you block the nerve. You have the person get up and walk around. If the patient says, oh my gosh, I feel so much better, you hit the right spot. With 90% accuracy, you can go ahead with a hot needle where the very tip of it has an electrical current run through it, and it gets very, very hot. And it can burn the tip of the nerve, just like you're pruning back shrubs in front of your house. These are sensory nerves. You can do that to sensory nerves. You can't do it to nerves that are mixed, where they have some kind of sensory and motor function, or on a straight motor nerve, because it forms what's called a neuroma, and your pain problem can get worse. The sensory nerve itself does grow back. 6 months to a year, something like this is repeated. What is the procedure? You lie on a table, fluoroscopy is used, the lumbar spine is identified, and the nerves travel in a reproducible course. And you block the nerve, and then you put the hot nerve on it. This is used when other modalities have often failed, but can be a primary modality when most of your pain is worse when you stand, most of your pain is improved with sitting, as well as most of your pain is in your back. Next slide, please. Spinal cord stimulation. This is nerve modulation. So we discussed ablation, which stops the pain at the source. Nerve modulation tries to stop the signal of pain to the brain. This can be used for mechanical pain and neuropathic pain. The device itself uses an electrical signal actually fairly far away from where the problem is. If you took that same person that was bent over, grabbing their back, to grab that area is actually in the thoracic spine at T8, 9, and 10. An electrical current is run through the very fine nerves that come up that location, and it stops them. It's like taking one of our expressways, I-96, I-75, shutting it down, putting cones across, and the pain fibers can't make it through. Pain is not really that simple. It's plastic in the sense that it'll form new ways to try to get to the brain. So it's very important to realize that nerve modulation has to change. I've done quite a few studies, and quite a few of those studies has been with Boston Scientific. One of their studies looks at using different types of stimulation and then rotating different types of stimulation so that pain fibers cannot try to get around our roadblocks. And it works. It works very well. It takes success rates, which could be about 70% after 2 years, and it bumps them back up to the 80 and 90% that we had when we first placed these devices. What you're looking at this screen right here is spinal cord stimulation as presented by Boston Scientific. There's quite a few other companies that do it, and you may have someone or yourself with a different type of stimulator in your system. This is a very good system because, as you can see, those are the leads that come out. We're very fortunate now with the leads that the small percutaneous leads, which are the round ones, can be used in almost every situation without having to use the larger paddle leads, which require a surgical laminotomy where part of the bone has to be removed. So the ways to put it is very simple. The way to take it out is very simple. It can just be an incision and this device can come out. This is also a very good device because it's programmable multiple ways, as well as the device can be rechargeable or non-rechargeable. And that usually is dependent on how often you use it or how much area that has to be covered. The device is also great now because as long as your system's fully functioning, that means that it's hooked up and all the contacts are working, you can have an MRI scan, full body, which is great. It was a limitation in the past, and it's not a limitation now. Next slide, please. Spinal cord stimulation, who can benefit? When I started doing spinal cord stimulation, we used to have 2 contacts. Could you go back to the previous slide? If you look at all those little leads that come out from the programmer that's just to the right of the now let's discuss spinal cord stimulation, those are each little contacts on those leads. This is the only company that gives you 32 of those contacts. Most every other company is 16 contacts. No one else goes as high as 32. There was a company that went up to 24. It's not around anymore. But this company here is wonderful because with those 32 contacts, you can go to multiple locations. If you're a patient of mine and I say, you know what, I'm going to choose this company's stimulator for you, often it's because I know that you will have head and neck troubles as well as arm troubles, which include back and leg troubles. I can capture all of that with this device. Next slide, please. Who benefits? Nerve pain. Nerve pain does wonderful with this. Nerve pain such as that pinched nerve we discussed earlier, where you have sciatica after you had a bad disc and it didn't go away, that works wonderful. Failed back surgery syndrome, when you have scar tissue pulling on nerves continuously in your spine, and there's no real way to go back in there and open that scar tissue up without causing more damage. Those strange pain problems like complex regional pain syndrome or reflex sympathetic dystrophy, those problems where the stimulation for pain is gone, but you still have a hand you can't use because every time you move it, it hurts. Those people that fail things like ablation of their lumbar spine, and those people also that have vascular troubles in their limbs or their legs, This works wonderfully to make it so not only you have better tissue flow, but you also have less pain. Next slide, please. How common is this? It's very common. The amount of companies have grown dramatically since the 1980s, when this was first started to use in clinical practice. And then the amount of devices and their capabilities has grown tremendously. One of the largest impacts that makes this device work so well was the 2016 war on drugs, in which every person that was taking more than 2 opiate pills a day, or a large opiate pill twice a day, was cut off, so that people needed something for pain. So this device became very popular at that time, and the Boston Scientific Company and the other companies have not disappointed in doing the research and making sure that our patient populations have the options and the ability to help decrease their pain. Next slide, please.
Hey, Dr. Washabaugh, real quick, we have a question from a patient. Just one of them's asking, as you went through some of the things that spinal cord stimulation is useful for, would you say that it is useful for chronic gut pain? Someone is asking.
It can be. It's not one of the easier things. That's visceral pain. So we talked about mechanical pain and neuropathic pain. Visceral pain can be very odd, because visceral pain can be a bad organ. And bad organs usually are, if you cut an organ doing surgery, you could, as long as it didn't hurt to have your stomach open, you could cut an organ. But if it's inflamed or if it's stretched, that's very painful. That's a very hard pain to take care of. So an off-label use, but quite a few studies have shown that if the leads are placed in the thoracic spine, it can help with chronic abdominal pain. And that's almost taking all sources of chronic abdominal pain. The most common is chronic pancreatitis. Hope that answers your question.
Thank you.
How does spinal cord stimulation works? We talked about this in a little bit. You can see on the left-hand side, you see flexible leads go in the back. It goes into a generator, and it goes ahead above where the nerve comes out of the spine, and it changes it so that the pain fibers can't make it up to the brain. The system is trialed first, and that's one of the best parts about this, is that you can trial this system for anywhere from 3 to 7 days and know how it's going to work for you. And then once the permanent one goes in, it can also be modified in the future. Let's say you need an extra lead put in. This device lets you go from 2 leads to 3 leads. Other devices don't let you do that. Go ahead and play the video.
If you live with chronic pain, you know how all-encompassing it can be. It robs you of the things you love to do. It strains your relationships. It makes even the smallest tasks unbearable. And no matter how many procedures you've had to endure, or medications you've been given to try, we know that one-size-fits-all therapies may not give you all the relief you need. Boston Scientific's spinal cord stimulation therapy is different. Spinal cord stimulation, or SCS, is a safe, drug-free, FDA-approved pain management therapy that's clinically proven to help reduce chronic pain. And with Boston Scientific's SCS systems, your therapy can be personalized to your unique needs and preferences. Here's how it works. When you feel pain in your back or leg, for instance, it's because nerves from that part of your body are sending pain signals through your spinal cord to your brain. It happens in a split second, so it feels instant. But the truth is, you don't actually feel pain until your brain receives a pain message from the part of your body that hurts. SCS is designed to interrupt those messages using a small electronic device called a stimulator and thin, flexible leads. Similar to a pacemaker, the stimulator is implanted under the skin where it generates mild pulses. Those pulses travel through the leads to nerves along the spinal cord, and interrupt the pain signals en route to the brain. Most SCS systems replace the feeling of pain with something called paresthesia, a kind of soothing sensation that can reassure the patient the therapy is working. Other SCS systems produce no paresthesia. Boston Scientific's SCS systems offer both options, giving you the flexibility to choose from a range of sensations, or, if you prefer, no sensation at all. Boston Scientific's SCS systems can also deliver more than one type of stimulation at the same time, even to multiple areas, giving us a better chance of finding the right treatment for your particular pain. Results of a clinical study show that when patients can choose between multiple therapies in one device, they achieve better overall pain relief. Another great thing about SCS is that you can do a trial with a temporary system first to see how it works for you. Your doctor will position the leads in your back and then connect them to an external stimulator that's worn around your waist. For the next 3 to 7 days, you'll be able to test drive the device, experiencing what SCS feels like as you walk, sit, sleep, and just go about your life. Most people who try a Boston Scientific system feel significant relief. In fact, in a recent clinical study, more than 90% of patients who tried our system decided to go forward with the implant. Over 96% of patients said they would recommend Boston Scientific's SCS systems to other people suffering from chronic pain. In another study, patients with severe back pain reported an average drop in pain score of nearly 6 points, even 2 years after getting their Boston Scientific SCS system. The effective, long-term relief from chronic pain your Boston Scientific SCS system provides can help you reclaim your life and many of the activities you used to enjoy. Talk to your pain doctor about SCS. Learn about the benefits of multiple therapies and personalized pain relief from Boston Scientific. For more information or to find a pain specialist, visit
Great. I think that's the end of that YouTube video. I answered a couple questions off the chat while that video was going on. One was, how can you improve sleep? And treating pain helps sleep tremendously. Are there sleep aids? Yeah, there are sleep aids. Do you control with sleep aids? Yeah, some people do take sleep aids and don't wake up. And that's one of the problems we got into with the opioid crisis. Another question that I asked was, are there different types of medications if you have allergies? And there's always different types of medications. And not to put a pun out there, but you have to be patient. That's often you have to do 2 to 4 week trials with the medication, decide if you like it, then stop it. And there's been so many different types of either pain medicines or adjuvant medicines. Those are medicines like antidepressants or anti-seizure medicines that have been used first for something else, and they were found by clinical research to help with pain. So if you go that route, there's an awful lot of different medications that can be tried. But the reason why medications aren't pitched is because they just don't work as well. If you get 50% better on a medication, that's about as good as you'll ever get. And tolerance is often the biggest problem. That's why devices such as ablations, as well as fixing the problem, or nerve modulation with spinal cord stimulation is so popular. How would you know if you passed your spinal cord stimulator trial? 50% is the nationwide improvement. But I always tell patients that it has to be as good as 1919. That's the invention of sliced bread. If you say, oh my God, this is the best thing since the invention of sliced bread, you're going to do great. You're also going to do great if you say, you know what? Can I leave this in for a couple more days because I love it for your trial? You're going to do great. If you come in after your trial and go, well, I just don't know if I like the way it felt, or my back hurt because they poked through the skin to put the leads in, or if it doesn't cover the area properly, you're not going to do well. You would not go through the permanent placement. The next thing that's really important is, can you do some functional stuff that you haven't been able to do? Functional things such as do the gardening, go for the walk, play with the grandkids, sleep better, All those kinds of things. If you can do that, the stimulator is definitely better for you. Next slide, please. Spinal cord stimulation is now very much personalized. When you go through your trial, there will be multiple different programs that will be tried in order to find out not only where the leads will work the best. This device, when we trial it, we put 16 contacts left and right in that sweet spot of the spinal area, which serves your pain. So they can go up and down from, is it best at thoracic 7? Is it thoracic 8, 9, or 10 that gives you the best pain relief? As well as how much energy is used in order to give you the pain relief. And from that, we have a very good idea of not only where to put leads, but what kind of program is best for you, as well as what kind of generator, the battery, which one's best for you. So it's a very important time during that trial, not just pain relief, not just improvement of function, but also what kind of long-term therapy you can look for. Next slide, please. Safety. Spinal cord stimulation is extremely safe. Will it paralyze you? No. I'm certain someone has been paralyzed from it before. Some people have had to have had some kind of complication, but the percutaneous placement of a spinal cord stimulator is extremely safe. When you have to go to a surgeon for a paddle lead, your risks go up. Your risks for bleeding, infection, or nerve injury do go up. But a percutaneous placement, that's using a needle to place those round leads we looked at for quite a bit, is very safe. And how well does it work over a long period of time? Over 1 year, all companies, everyone does great. The 2 and 3 year mark, you can see on our slides here that the pain score of 0 to 10, where 10 being the worst pain, you still get a significant reduction of pain at the 2 year mark using the Boston Scientific product. And this does not include the newer programming, which makes it so that the 8.6 versus the 2.9 is still even better with the products that are out now for people. Next slide, please.
Dr. Washabaugh, just real quick, we had 2 questions from patients. One's asking if spinal cord stimulation can work for fibromyalgia. And the other question that came along is somewhat similar, just asking if it could also help with rectal pain. So 2 specific disease states.
2 specific disease states, but you can see what the difference is. Fibromyalgia is diffuse pain with trigger points throughout the body in multiple different regions of the body. If someone had rectal pain, that's very focal. That's very focal, very easy to get a hold of. So if you look at the 2 different syndromes, fibromyalgia patients would be much harder to capture. Rectal pain would be much easier to capture in order to make it so that you don't have pain long term. If you were going to try for fibromyalgia pain, I would definitely use a Boston Scientific device, because you're going to have a lead placed in the neck as well as one in the middle thoracic spine if you want to try to cover those areas. For the rectal pain, those are actually much easier because you only need to have coverage over the rectum. And this device, when placed in the thoracic region, will take care of your pain from your belly button on down to your feet. Now, when I say that, it doesn't mean that if someone stabs you in the back, you're not going to feel it. It just means the chronic pain that has those fibers all revved up, those are the ones that get taken care of with the spinal cord stimulation. Thanks for the questions.
Thanks, Dr. Washabaugh. We're just going to kind of switch gears here for a moment, but feel free to continue to put questions into the chat. But we do have Robin with us, and she is a patient ambassador, and she's volunteered to be part of this program for over 12 years. And she's here today to tell us a little bit about her journey and her pain story, and certainly would be willing to also answer any questions you might have from a patient perspective. So I'm going to go ahead and welcome Robin and turn things over to her.
Great, thank you. Thank you for the invitation and allowing me to speak and to share my story. Hopefully it helps somebody, some information. So just to kind of get started, I've had my spinal cord stimulator. It will be 13 years in November, and I really can't imagine what my life would be without it. It has given me back so much of what I lost when I was in pain. So just to kind of back up a whole lot here, in 2005, I was a very active tennis player, taekwondo, very active individual. I had 4 teenage boys at home. And while running a simple errand one day, I was in a nearly fatal accident. I suffered a great deal of injuries and they were being treated. But about 3.5 weeks after that, I was in a second car accident and they were finding more injuries that happened. And then 2.5 weeks after that, I was in a third car accident. And, you know, I was not driving. I mean, I was not at fault for any of those. But as a result of those accidents, I suffered a significant amount of injuries to my neck, to my shoulders, to my chest, my hands, my arms, my low back, mid back, legs, feet, brain damage, even separated my kidney. So I suffered a great deal of injuries, but at some point, all those things were being treated and taken care of. But during that process, I developed chronic pain. And it was no fault of a doctor, no fault of anything I did or didn't do. It's just I began to be a chronic pain patient versus being an injury patient. And with that came a different routine of what needed to be done to try to take care of my pain. And every gamut, I mean, everything that could possibly be tried was tried. Now my pain is across my low back and down my left leg. And it was an unwanted continuous companion. It didn't matter whether I was in 3 car accidents or I had, you know, stepped off a curb or whatever, I was in pain. So cause is not the important thing here. I was just in chronic pain. And everything was tried. I mean, short of voodoo, everything was tried. So nerve ablations, opiates, muscle relaxants, NSAIDs, acupuncture, TENS units, chiropractors, years. I had almost 4 years of physical therapy trying to alleviate some of my pains and my problems, and everything would help short term, but nothing was ever a long-term fix. The pain was always lurking right around the corner to come back and be there to let me know who was in control, who was in charge. And at that point, I was weighing and measuring my entire life by how much pain I was in or how much pain I was going to be in. And that was really a difficult time because I always had pain. I mean, brief moments of where I didn't, but that would, you know, quickly pass. And it was so bad that my children didn't even feel comfortable to be able to walk up and give me a hug because they were afraid, you know, it would hurt me or it would startle me or something like that. So that was a pretty devastating thing to have 4 teenage sons at home and nobody could just walk up and give mom a hug, whether it was for fun or whether it was because mom needed a hug. It also severely impacted my reliability. So the problem was I could say, yeah, you know, yeah, I'll do this, or yes, I'll cook this for some event or something like that. But then I'd have a bad back day, and the bad back day would mean muscle relaxers and opiates and ice packs. And just because I said, yes, I could, didn't mean I could actually fulfill my obligations. And that was a very difficult time as well, because I was a very engaged individual. And what happened is my life, I became a spectator in my life and the lives of my family and children, because all I could do was observe. I could no longer participate. So after all the treatments were tried, and like I said, everything was tried, antidepressants, anticonvulsants, you name it, everything was tried, trying to give me some kind of relief from this chronic pain. And then one day while I was at my pain management doctor's office, he looked at me and said, "Hey, have you ever heard of a spinal cord stimulator?" I hadn't. So he gave me a brochure and a DVD, sent me home with it. And, you know, because my husband is also, and my family were all involved in my recovery and my pain and so on, we all sat and watched it and said, you know, I've done everything else. Why not give this a try? So my trial was set up, and I'm hoping, you know, fingers crossed and hoping that this will be the solution. And I'm in the waiting room, waiting to be called back to the procedure room. And you know, I'm miserable. I'm in pretty rough shape. They call me back and they prep everything and they put the stimulator in. They said, okay, we're going to turn this on. And it's like, okay. So they turned it on, and I promise you, as sure as you're sitting here listening to me, it was like that, like somebody flipped a switch. I went from being in agony and in chronic, constant, annoying, just frustrating pain to my pain was absolutely gone, wiped out. And it was so immediate and so absolute that I actually looked at them and said, hey, can we skip the trial and just go straight to the permanent? Now, that wasn't an option, but that's how immediate my relief was. Now, it's my understanding not everybody gets that immediate, full, encompassing relief, but the best part about it was I got to try it. It wasn't, hey, let's take this medicine and see if it works, because that's money, that's time involved. Let's try this procedure and see if this works. Let's try this physical therapy, see if this works. This is something I got to make that educated decision, and they did it, and I could go, hey, this helped. So let's move forward. So then my permanent implant was scheduled, and it was scheduled in late November of 2009. And I have never regretted, looked back, or anything about that decision. It has made all the difference in the world. 2 weeks ago, my husband and I drove from where I live to go see our grandchildren and our children, which was a 14-hour drive. I would have never been able to do that without the stimulator, let alone enjoy the process of visiting with the kids and the grandchildren, because I would have been miserable. I'd have been medicated. There's a lot of gaps in my previous life because of all the medication. I actually get to enjoy my life and participate. I don't, that chronic thought or that constant thought of, hey, how much pain is this going to cause, no longer is in the forefront of my mind. Now, with that, I'll tell you, it's not a cure. So whatever is causing my chronic pain, if I turn my stimulator off, it's going to take about 20, 30 minutes, and I'm going to start hurting again. Within an hour, I'm really going to be miserable. So I don't turn my stimulator off. My pain is 24 hours a day. So my stimulator is on 24 hours a day. That's what's nice about this. You can turn it off and on, up and down. If you're having more pain because maybe it's a cold, damp day, you may need more stimulation. And that's what's nice. There's a remote control. So this is my remote. This is how I can turn it on and off. I can change to different settings. And so when the doctor brings up about being personalized, it's personalized to me. You could take 100 people and we all say we have lower back pain, and the likelihood that all of our programs are the same are going to be, it's not going to be, because everybody's body is different. Everybody's pain is different. Their tolerances are different. And that's what's so nice about this. It is completely personalized, unique to my pain and my problems. So like I said, it's not a cure, but it is a treatment that is long lasting, long term, and it doesn't impact or degrade my mental capacities. And like the doctor said, if someone stabbed you, yeah, you're going to feel it. If I run into the nightstand with my shin or stub my toe, I feel it. If I overdo, I feel it. But the thing is, that pain is meant to go away, and it will go away. The chronic pain never goes away, and it serves no purpose. Pardon me. And, so it's not preventing you from knowing if you've hurt yourself or you've strained yourself. If I go work out, I'm going to have muscle pain. If I'm going to go out in the yard and rake my entire yard, I'm going to probably have pain, but that's going to go away. So this is taking care of that chronic, that obnoxious, serves no purpose pain. Now, I do this as a volunteer because I went through many years of physical therapy and all the procedures and treatments and also surgeries trying to alleviate my problems and my pain. If I can prevent one of you or help one of you to eliminate or reduce your pain, then there's a reason I survived the car accidents, the surgeries, the years of therapies, the medications and everything. There's a reason I survived. And if it's to share my story so that one of you has a better quality of life, then there's a reason I survived. It gives a value to my experiences. This is a volunteer thing for me. So I enjoy doing this. And I hope I helped you, and I hope I maybe gave you some hope that there may be a solution for you. So thank you.
Thank you, Robin. We appreciate you being here and sharing your story. If people have questions for you, we encourage them to send them to the chat, and then we'll try to get to some more of those questions. And if you've submitted a question and it hasn't been answered yet, then we will try to get to all of those towards the end. Dr. Washabaugh still has more of his presentation, so we're going to do that. But we do appreciate you, Robin, and thank you so much for sharing your story.
Sure, thank you. And I'll be around for questions as well.
Thank you.
Uh-huh.
Okay, so Dr. Washabaugh, I'm going to turn things back over to you and advance the slide for you.
I've been answering a few questions on chat back to the people that have sent them, so feel free to send the questions. Let me go through a few of them. One asked the question, I have numbness in my legs and it hurts. Will it help that? Spinal cord stimulation helps that tremendously. It's a wonderful device. And that's a very easy way to get coverage. But also I had a question about a pars defect. And the pars defect is when your spine doesn't quite come together right. It's not spina bifida, where you have an open spine and your nerves don't function. But it's when the bones come in crooked. And the bones are there to protect and to give stability. But when they come in crooked, they sometimes start to form a false joint. Other people have false joints in their back from the arthritis, or they have very large transverse processes that grow into the sides of their hips. And those can all be painful. The usual thing would be to try to stop the pain at the source. The ablation we first talked about, the hot needle, works very well. But when you go to a stimulation is not fixing the problem, like Robin said. It is stopping the signal of pain to the brain. So anything from your belly button on down gets modulated. So it can be from the pars defect. It can be from the L4-5 lumbar disc degeneration. It can be from sick nerves in your leg. It stops that pain, and that's how it works. So nerve modulation can be used in a region that can have pain from multiple different sources. All right, let's talk about fixing the problem at the source. As we've gone through my career, as well as this journey through pain management, as it's become more procedural. And before this device was owned by Boston Scientific, I was trained in this device and was taught how to use this device. And that's called the Vertiflex, which is a very, very interesting procedure. When you have the little holes where the little nerves come out, and the nerves come out right where the discs are. So either the disc is pushing back on the nerve, or that hole gets small because the disc got small, and you have pain that's in your back or down your legs, and it's improved tremendously with sitting and much worse with standing and walking. You often get an epidural steroid injection first to see if inflammation can be taken away and open the hole. If that doesn't work, that little purple device, which is a 12 millimeter device, goes in with something that looks like a marker. And that marker goes in and you twist the marker and those little wings pop up, and those little wings will pop up and then decrease your pain. Next slide, please. It opens those little holes so that when you're up walking, with standing and walking, or if you're the kind of person like the third person to the right pushing the empty shopping cart, because just that leaning forward opens those little holes up, you're perfect for something like this. The holes get closed off and it gives you pain. This thing makes it so it's like you're sitting again, even when you're standing. Next slide, please. And here's the pathology shown much better. You see the healthy slide and the stenosis slide, and that red area shows areas that are being compressed, often from degeneration of the disc or having a bad joint. When that device goes in that backside area, when you stand up, it doesn't get compressed any longer. Next slide, please. This is FDA approved. And as you can see in the slides in the middle, you have the red nerve that's getting pinched when someone stands up. You put the Vertiflex in there, it keeps the hole open, and that hole open makes it so that you can have long-term benefit. I've put in maybe 100, I could be more than 100 of these. It can come out. Let's say you don't like it. Let's say it didn't work for you. Let's say just the idea of having that put in your back and not working, you don't like it, it can come out. It's not fun to take it out, but it sure can come out. What kind of recovery time do you have? Usually not much at all. We say no bending and lifting for the first month, but usually as you age, your back doesn't bend that much. When you're 20, your back is very mobile. When you're age 50, it's not very mobile. It starts to get compressed. The same as you age up higher. Next slide, please. Results, phenomenal. Works very well for people. It can be put in more than one location if it's contiguous, especially, or you have to come back if it's non-contiguous for another procedure. And it really helps with the leg symptoms when you're walking, as well as the back pain. This is one of the devices that, will you be able to stop your pain medicines when you're on it? The answer is mostly yes. Most people get off their pain medicines once they have one of these placed. And will you be able to walk farther and have better physical function? The answer is yes, most people do. 4 out of 5 people do. So wonderful device, works very well for people that have that kind of pathology, and that is pain that improves with sitting, worse when standing, and it's from the nerves getting pinched by your MRI scan. Next slide, please. I'm looking at my chat right now, and I just got a nice, Harriet said, can it slip out of place? The answer is yes, it can slip out of place. 2 things make it slip out of place. Number 1, that is if you have something called a spondylolisthesis. The spondylolisthesis makes the one area slip above the other area, and that can slip out of place. Or 2, if you really have a mobile spine, if you are the person that should not be bending over too much afterwards, it can slip out of place. What can be done after that? It can be taken out. It can be left in place. It's not going to hurt anything. It can be put back into the original place. Or you can look at the possibility of having an open fusion with a surgeon. So I hope that answers your question. Another question here I have you ever had one move out of place? Yes, I have. I had one move out of place, and it was found only because I was doing a fluoroscopic view after they came in for their office visit to check it, and it moved out of place, but they were still having phenomenal pain relief from it. So we did not remove that. I had one move out of place where the person didn't want it in their back any longer, so I had that one taken out. And with it in or out, it did not help their pain. So they were not the right patient for that. All right, I'm ready for more questions.
Dr. Washabaugh, did you see the question from a patient that says they had an ablation and then they've done epidurals, they had a laminectomy? What do you think about SCS working for them?
I'm looking for that right now. Okay. I had an ablation test and it didn't provide any relief. I also had several epidurals that also didn't work. Lastly, I had a laminectomy so that they removed that bone, the very backbone from L2 to L4 with no relief. Will SCS work for me? The answer is mostly yes. If your pain is from your belly button on down to your legs, it'll work for you great. Next question.
I might be able to help you with this one. It says, did you say you have an office in Adrian? And the answer is yes.
Yes, our Adrian office is next to the Bixby Hospital, which is now closed, and procedures are then done at Hickman Hospital. Procedures that are done at Hickman Hospital are the ablations, as well as an occasional Vertiflex. It depends on how much operative time we can have. Spinal cord stimulation is not done at the Hickman Hospital because ProMedica does not allow that to be done because of their financial recruitment, where they feel they don't make enough money to have it offered to patients. So those patients do come up to the hospital in Ypsilanti to have it done. So it is a drive.
Someone is
other question.
also, oh, sorry. What? someone was asking if other physicians within the practice perform these procedures. And did you want to go ahead and respond to that, Dr. Washabaugh?
Sure can. The all three doctors, Washabaugh, Chattis, and Bojrab, do all these procedures, and they've all done a lot of these procedures for a lot of years. So if you're in the practice already, then you should be able to have free reign to talk about any of these three types of procedures.
I had a patient asking, what about multiple degenerative disc?
The degenerative disc, everyone's got them. As you age, your discs degenerate, and some people have horrible back pain, and they go ahead and they get the MRI scan, and their primary care doctor goes, "Yeah, it doesn't look that bad to me," but it's bad for you. You're hurting like there's no tomorrow, and you're not crazy, and you're not faking. The disc itself, either mechanically or the juice inside of it, can come out and cause pain. So multiple degenerative discs in the lumbar spine. There are other treatments out there now where we actually just do what's called a discography. And if your insurance covers it, we give what's called an allograft. That's like fresh disc material and put it in there, and it forms a hard new disc. That's a tough one. Medicare is the best coverage on that. Many people that need it have Blue Cross, Priority Health, Paramount, and they don't cover it. So that's one avenue that can be done. As well as when you have a bad disc, the disc itself grows, the bone gets unstable. And you can see that in the MRI scan. And there's a device now that you can put into the spine that can go ahead and burn the nerve inside the middle of the bone of the spine. And that takes away pain for people long-term, which can be used. Can you modulate pain for discs with spinal cord stimulation? Yes, you can. Even though it's mostly mechanical pain, and mechanical pain sometimes doesn't cover as well with spinal cord stimulation, it can be trialed, and many people have had benefit from it. Next question. I'll quit going through my list of questions because they're coming, and I appreciate it.
One here says, I had the Vertiflex procedure placed not quite 2 years ago. It worked well until recently, and now I have recurrent pain with walking. Does this mean that it has slipped?
An x-ray would tell you if it slipped or not. You might need a Vertiflex on one of the levels next to it. So adjacent, 5 vertebrae. And if you have one, you have 4 other ones that are sitting in the same neighborhood. And if one's a bad actor, you have other bad actors that could be coming. So what I usually do for something like that is just have the patient come in, especially if I have fluoroscopy available, just look at the Vertiflex to begin with, see if it slipped. If not, I like either an x-ray or an MRI scan or a CAT scan to see what can be causing that pain at this point. Next question, please.
There was one in there posted asking if you do the spinal cord stimulation implants as well as the trials.
Yes, each doctor does their own trial, each doctor does their own implant, and each doctor has you come back after the trial to have a physician assistant take the trial lead out. And what the best part about that is that it's a third party. Honestly, I mean, they work for the practice, but it's a third party that says, like, is this going to help them or not? And physician assistants want the patients to get better from the procedures that the doctors do. That's all there is to it. They don't want to hear about it on call. They don't want to hear about it any other time. So if you're not doing well, they'll say, you know what, they didn't do great. And they'll let us know. So the decision is made by the patient, the doctor, the physician assistant. And that makes it so you have the opportunity to really be having the right procedure for your problem.
Another question here asks, is there a procedure to place a man-made disc in place of a bad disc?
The answer is yes, for the lumbar spine only. And it's not a physical spacer like a surgeon would put in. What you do is you take one of those needles, you put it inside the inside the disc, right in the middle. Then you inject actual disc material. And that disc material then grows into the bad disc material and makes the disc stronger and more resilient. And that's how it's done. So it's a very simple procedure to be done. It's called an allograft, ALLOGRAFT, allograft. Next question, please.
Dr. Washabaugh, we still have a few people submitting questions. And while they're doing that, do you mind if I launch this survey just to get some feedback from tonight's webinar while we're continuing to answer questions?
That'd be fine.
Okay, so everybody on your screen, you should see a poll show up and it's just select the corresponding answer. No one will see your responses, but if you can't see the submit, it probably means you need to scroll down farther. So if you're having any issues submitting your survey, just know that you have to scroll down a little bit. If you would like to take it, we would really appreciate the feedback because that helps us to improve and continue to provide these educational webinars to you.
Also, continue to post questions if you have them to the chat feature for either Dr. Washabaugh or Robin. One of the ones on here, Dr. Washabaugh, is if you've had a mild procedure on L3, L4, and L5 and you're still experiencing pain, would a stimulator be the next step?
I was just typing that to Jan, but I'll speak it. The mild procedure and the Vertiflex procedure both treat stenosis, tightening around the nerves in the spine. The Vertiflex treats the central stenosis as well as the nerves going out from the sides. So if you're a candidate for the mild, you are definitely a candidate for a Vertiflex. If you're a candidate for a Vertiflex, you are not always a candidate for a mild. So the Vertiflex really is a more inclusive procedure. The one downside, Jan, is that at the L5 and S1 level, you cannot place a Vertiflex. There's not enough bone back there to put the little jack in, so it doesn't work. So if most of your pain is coming from L5, S1, it would fail. So it's done 2 levels contiguously, and if it's L5, S1, it would not work. So it's a possibility that Vertiflex would work for you. With spinal cord stimulation, a trial for spinal cord stimulation for pain from your belly button down to your toes is easy and an excellent way to treat pain long term. So that a trial would be wonderful. Next question, please.
One question from a little while back is, does a discogram show which of these procedures would be best for me?
Possibly. The problem with a discogram is that they're painful to begin with. And the whole idea of a discogram is that you are going to pressurize the disc. It's felt by most of medicine that if you sit and you can't tolerate sitting, it's going to be a disc. If you stand, can't tolerate standing, it's either going to be those joints that we burn by ablation or stenosis. Most people have mixed pain. Now you're going to go ahead and take someone whose back is hurting them quite a bit. And having done thousands of procedures on people, when someone has a region in their body that hurts, even if you sedate them, even using the local anesthetic on the skin, has all those nerves revved up so much, it's very painful. So to do a discography, you inject discs to see which one is the most painful disc. And often surgeons would send us patients to say, do a discography. They have 3 bad looking discs on MRI scan. I want to do a fusion on only 2 out of the 3. And we'd go ahead and decide if we can make that determination. So the answer is a qualitative yes, if you can tolerate needles being placed without a lot of sedation. If you're totally sedated, all we have to go on is your pain worse with sitting, as well as what it looks like when we inject the dye. Does it spread all over the disc because it's so degenerative, or does it stay put where you would not have to have a disc procedure? Long question, long answer, sorry. Next question, please.
One other
One of the-
question posted is the maker of the devices working on a way to secure the device for people with too much spondylolisthesis movement?
That question I do not know. I know that before Vertiflex came out, spine surgeons started off with something called the X stop, and that was done back in about 2000s, which looked like an X that went in the back, and they loved it until they didn't, because it would either slide out of place or it was just too traumatic to put in. And there's other devices that can go in that do the same type of fixation. That device itself, I do not think that Boston Scientific is doing anything. If they do, I'm not part of that. Next question, please.
One of the questions here says, do you perform the allograft procedure, the electrospinal decompression procedure?
Electrospinal decompression procedure. I'm not certain what that is, Robert. I see that. I'm just not certain which procedure that is you're talking about. But as far as the allograft, yes, we do the VIA disc. It's called VIA-DISC, and it's a very nice device. And it's simple to use. The whole thing takes about 10 minutes to mix it up, about 10 minutes to put the needle in the right spot, and then you recover. And you can have sedation for that. So that's a very simple procedure to have done. Problem is insurance coverage. Next question, please.
Will any of these options keep me from having to have a cage implanted?
You have to have surgery on your spine if you have fracture or instability. Now, what kind of surgery is that? A fusion is only really done for instability of the spine. You have a spondylolisthesis that's active. And you'll find that if you have back pain, they do x-rays, and those x-rays you bend over and then stand up, then extend backwards. That's to see if you have abnormal movement from spondylolisthesis where the discs and vertebrae move on each other. If you have that kind of a problem, your chance of having back surgery is 50%. So with that said, it's 50%. If it's pain that you would have a cage put in for, pain, it's not going to work. So difficult to have any kind of spine surgery for just pain. If there's nerve compression, a decompression of the spine for the spine surgery works very well. But that's a difficult question to ask. But usually if it's because of pain that you're going to have that cage put in, these would help stop the pain. It would avoid the cage. Next question, please.
A couple other questions came through. Is spinal stenosis between shoulder blades and lower back and buttocks?
I'm sorry, one more time, Brooke.
Sure. It just says, is spinal stenosis between shoulder blades and lower back and buttocks?
Okay. Yeah. Often if you have 7 vertebral discs in the neck, you have 12 vertebral discs in the thoracic spine, and then you have 5 in the lower back. Whenever you lift something, carry anything, it all goes to the lower back. The chest wall is often supported by the ribs. So thoracic, most of the time, is spared. But if you have something bad in your lower back, it can be bad in your neck also. And sometimes just treating the neck treats the lower back also. So stenosis in the neck can be treated with spinal cord stimulation. The Vertiflex does not go in the neck. It's not FDA approved for that. Ablation can be done in the neck. The one thing with neck stenosis is if you're dropping items, you're seeing the wrong doctor. You should be seeing a surgeon. Next question, please.
After having radio frequency 2 weeks ago, why would you have a burning feeling in the lower hip, top right of your leg?
When you saw the picture of the ablation, you saw the little nerves that were coming off the major nerve of the spine. So if the major nerve of the spine has any type of involvement, let's say you cut that branch and that branch dies back to the major nerve, you can have, it's often called dysesthesia, like unpleasant feeling without the weakness that goes into a leg. And that's from the ablation. The nerves grow back, so it'll be short-lived, that being a period of months at most, but that's what it's from. Next question, please.
I just had Vertiflex 5 days ago and still have some good pain when standing.
Good pain meaning significant pain, obviously. The Vertiflex often works right away. It does not always work right away. Give it 1 month to see how much it's helping you. What could have been done? Is there more than one level causing your difficulty? Is the Vertiflex not large enough for the one they put in there? Is there some other problem they're not treating that the Vertiflex can't get to, such as an already sick nerve that has been pinched for too long? So I would give it a full month before I give it an assessment. I'll get the x-rays though, anytime. Get the x-rays, see how it's sitting in there.
One other person asked, are you going to have another one of these sessions again? I have 2 people who would benefit from this session.
Usually each of the doctors rotates through once per year doing these sessions. But yes, they're very helpful because it gives you a chance to interact, number one. It also shows where pain management is at this point. We're very fortunate. We have the ability to do these kinds of procedures on patients to help them. Not all pain doctors have the ability, not because they're not smart or they could be technically good. You have to have the right setup around you. And we're able to have the right setup around us, so we're able to get these types of life-changing modalities out to people without long waits and to make it so it works. Next question.
One person's asking about if they were to have a spinal cord stimulation, can you still scuba dive? I can answer this one. You can scuba dive up to 1 atmospheric pressure.
So 33 feet.
The next question is, can ablation be used for SI joint pain?
The answer to that is a definite yes. In fact, there's special devices that have come on the market where they try to burn all those areas at once for the SI joint. The SI joint itself, they have simple fusions for it now, in which you can go ahead and put a little piece of bone into it. And that's done almost as slickly as the Vertiflex is to make it so that that doesn't cause pain any longer. So it can be ablated. Plus there's a SI joint fixation that can be done that is very slick and helps a lot of people with SI joint pain. And SI joint pain, unfortunately, looks a lot like hip pain, looks a lot like back pain, looks a lot like sciatica. So often nerve blocks are done to determine where the pain is actually coming from. Well, I'd like to thank everyone. I would like to thank Elizabeth for getting this set up for us. I would like to thank the other panel people. I would like to thank all of you that took the time tonight to view this as well as to ask your questions. And I wish you the very best luck you can have with finding the right modality to help you so you can get back to living your lives. Thank you.